So hello, everyone. Thank you for joining us. My name is Stephanie Yaman, and I'm the co-director research for the Center of Aging and Community and an associate professor at the School of Counseling, Psychotherapy and Spirituality at St. Paul University. We'd like to begin today with a territorial acknowledgement. Kwe Kakina, hello, everyone. Pija Shig, welcome. We would like to acknowledge that St. Paul University is located on the traditional unceded territory of the Anishinaabe people. We would like to honor the Anishinaabe, the first peoples of the lands and waters of the Mississippi. From the immemorial, we acknowledge that the city of Ottawa serves as the home of the Anishinaabe, as a place for spiritual ceremonies, cultural gatherings, and exchanges amongst First Peoples. Today, the spirit of peace and friendship is the foundation of relationships amongst Indigenous peoples and non-Indigenous peoples from around the globe. So on behalf of the Center of Aging and Community, I'm happy to welcome you to this presentation from one of our 2022-2023 Thomas Feeney Awards. And the recipient this year is Andrea Khalid. A few reminders before we get started. This conversation will be recorded and added to the university's YouTube channel. We will be sending out the link after the event. We invite you to keep your webcam open. Do not hesitate to send your questions and/or reflections throughout the conversation using the chat. We have some time for questions and answering following the presentation by Andrea. The Center for Aging and Community was created with a mandate to promote healthy aging through the optimization of quality of life and community resources. We aim to fulfill this mandate through innovative, collaborative, and interdisciplinary research, and on community engagement to raise awareness and create space for meaningful dialogue, important issues such as social isolation and spiritual reminiscence with older adults. The community engagement work of the center benefits from the leadership of Patricia Marston-Dole, the co-director of the center. I'm now going to invite Patricia to share with us some more information about the Thomas G. Feeney Award and how it supports important research in the field of aging and community. Patricia? Patricia, you're on mute.
Thank you. Yeah, the Thomas G. Feeney Award comes through a generous gift from the son-in-law of Thomas G. Feeney, who was dean of the law school at Ottawa University, and who on his retirement went to St. Paul University to do a degree in canon law. So we're very thankful to him and his family for this generous gift to the university. The purpose of the Thomas G. Feeney Award is to encourage students to look at some of the issues regarding aging, not only aging as in aging well stuff, but also in the community. And that's why it's very important for us today to listen to somebody who works with caregivers. This is increasingly a very important subject. So we're very pleased that we have somebody on the an award winner 2 years in a row, in fact, who has taken on this very important subject and who is a practitioner as well. So we have the benefit of two very important parts of the question of aging and community, and that is the Parkinson Society work that is done to assist caregivers, and also then the role of caregiving, and which is going to be an increasing topic in the healthcare business. So the criteria for this award are quite significant, and Andrea has been very successful in bringing forward a topic that meets these criteria. So the award is based on the aim of the project. That is the alignment of the project with what we are trying to do as dealing with aging in the community and with the community. The quality of the project, and that is the quality of the research. And as we all know, any of us who've done any methodology, that the quality of the research is very dependent upon the methodology. So that is one of the important highlights of the award. Feasibility, well, that means meeting timelines. And I have to say that Andrea has done that very well, 2 years in succession. And that meaning also that the objectives of the research will be met on time. And that in itself is extremely important because it deals with knowledge translation, mobilization, which is another important element that comes out of the research, that it does go into the community and adds to the knowledge in the community about the issues that we deal with. And increasingly, as we know, the boomer, I like to call it now, the boomer express is moving down the rail tracks. And we have to get the information out there, and really in a way to the emotional and technical support, research support that goes with that. So the competition this year, and we're hoping to attract lots of interest in it, opens on the, is open now for proposals. If you go to the website, and I think that that will be put up very soon on after following this presentation, and also it is already up, I believe, on the website for the university under centers. If you click on centers, you'll find it there. So with that, back to you, Stephanie, and we look forward very much. I look forward to what Andrea is doing because it crosses so many of the dimensions of my work out in the community. Thank you.
Thanks. So I'm going to start by introducing Andrea Khalid, who has a master's in psychotherapy. She's now completing her PhD in psychotherapy as well at St. Paul University. She's under the supervision of myself and co-supervision with Dr. Cynthia Bilodeau. She is a registered psychotherapist, did I say that? In Ontario. So a clinician and a researcher. Patricia introduced her research already, but I'll let Andrea introduce herself a little bit more and then get started with her presentation. Andrea.
Thank you. Thank you both very much. I really appreciate this opportunity to be able to share my interests with this community, because I think it's critical to what we're going to be facing as a community moving forward. In terms of, so yes, I am a registered psychotherapist. So I've been working in clinical work for about 6 years now in private practice. And before that, my previous life was working in clinical research as well and neuropsychology. So in terms of my interests, they really started quite a long time ago in terms of working with caregivers or care partners. My background is primarily in dementia, dementia-related concerns. And this is why I've chosen this research in particular to move forward with. Because I think that it's something that's up and coming, critical to caregivers and that population today and moving forward. So I'll just get started with my presentation. Just share my screen here. Grab it. Okay, so is everybody able to see it clearly? Okay, so what we're going to do is I'm going to be talking about identifying the needs and addressing gaps in the literature for Parkinson's disease care partners. So as I just mentioned, my research interests really are focused primarily on older adults, working with neurodegenerative disorders, working with care partners and caregivers. So these two terms are going to be, I'm going to be using them interchangeably throughout the presentation. Resiliency is another aspect that I'm very interested in, and as well as how we can utilize some of the things that we're learning from our research in clinical practice. So the purpose of this proposed research is very much to identify the impact and needs of PD care partners, considerations for psychotherapy, so how clinically we would be able to utilize this information to enhance the way that we work with this particular population, and as well as enhancing resiliency. So when we talk about Parkinson's disease, generally speaking in Canada, currently there are over 100,000 people living with Parkinson's disease in Canada and approximately 6,600 new cases per year. It is suggested that more than 40% are being cared for by their significant other. So what we recognize with these numbers is there's always already a significant amount of people living with the disease. And with over 40% being cared for by their significant other, it's impacting at a family level, at a couple or relationship level as well. It is also the third largest neurological healthcare cost after epilepsy and dementia. So Parkinson's disease, what we can expect with it is that we understand that it's a neurodegenerative disease, which does affect our motor abilities as well as our cognitive abilities. It mostly affects those around the age of 65 and older. However, there are a number of cases that are actually being diagnosed as young as 45 years old. They state that around 80%. We back, does that work? So it says that around 80% of those living with Parkinson's disease will actually develop dementia. When we talk about PD care partners and caregivers, who are we talking about? So we're talking primarily about informal caregivers. So these are people who are not formally trained in the medical field. They are usually family caregivers, significant others. So that's really who I'm talking about when I'm talking about caregivers and care partners. These are people who are caring for a loved one living with Parkinson's disease. Primarily, they assist with basic or more complex needs, so both physically and or emotionally. They are also coping with the diagnosis of Parkinson's disease. So there are a number of impacts that also happen, not only to the person living with Parkinson's disease, but to the one looking after them. So coping with the diagnosis, this could mean they are coping with grief, symptoms of grief, and adjustment to life, living with somebody with Parkinson's disease. Caring for oneself, this is another role that caregivers have to consider. They have to be able to look after themselves in the best way possible in order to keep maintaining and providing care for their loved one. Now, what is important is they need to also have access and different ways of developing coping mechanisms for both roles that they're going to be engaged in. So both as a partner and as a caregiver. When we talk about identifying needs, so we really want to talk about what are the caregivers' experiences? What is it that they are experiencing? And as much as the research and the literature has demonstrated already the impact on our caregivers, we also need to know, coming from them, what it is that they're experiencing on a day-to-day level. We would like to know what is lacking. So what is missing? What do they feel would be more supportive? What are the certain things that we can change as clinicians or in the psychotherapy field? What are the things that we can change to help them cope with what is happening? Also, the recommendations for research and clinical approaches. So, what has the literature demonstrated? So in my review, I read a number of articles, journal articles, looking at the impacts on caregivers. So what we have noticed, stress is actually doubled when caring for somebody living with a neurological disorder. So this is quite significant. And then on top of that, the stress is already augmented, but it is compounded if the condition is accompanied by cognitive impairment and behavioral issues. So this is another important note. Because we're already aware that about 80% of people living with Parkinson's disease will develop dementia, this means that there is a very good likelihood that stress will absolutely be compounded, because this disease will be accompanied by cognitive impairment and clearly behavioral issues as well. So one of the major things that we want to take a look at when we're looking at the research is caregiver burden. So this is a very common response to caregivers, generally speaking. However, I really wanted to look at what the burden was specifically with PD caregivers. So caregiver burden is when the role of caregiving has an adverse effect on the carer's physical, emotional, financial, and spiritual functioning. So this is the definition that we looked at in order to move forward and look at the impacts on burden. So the impacts of day-to-day living, as care partners are often in the role of bathing, feeding, administrating medications for their loved ones. And also what we're noticing is, with these changes happening, there are changes that do happen within the relationship as well. So as I mentioned before, so aspects of grief, the focus tends to shift to the person living with Parkinson's disease. So all of the doctor's appointments, all of the supports, a lot of it has to do with the person. So this actually changes how people look at their relationships. And as well, priority. So the priority technically usually does become the person living with Parkinson's disease. So that's going to absolutely have an impact on burden for the care partner. Part of the role as a care partner is also to provide social and emotional support to their loved one. This tends to be one of the first things that diminishes with the progression of the disease. So social supports are incredibly important to caregivers and for their well-being. But at the same time, they are the first things that tend to kind of go by the wayside. So because they are caring so much for their partners, they are unable to attend certain things. Their social lives definitely change. Socialization changes. So this is a significant impact as well that we're noticing that has an effect on burden. So when we're talking about burden, some of the things that have been noted in the literature is very much the presence of non-motor symptoms tends to increase burden. So with that respect, we're talking about the cognitive changes, emotional challenges, and in the next note, MCI, so mild cognitive impairment, has a significant impact on burden as it invokes higher levels of stress and lower quality of life. With the increased burden, the risk of psychiatric illnesses for care partners increases. So that would mean symptoms of depression and anxiety, and care partners actually describe a lower quality of life. Between 12 to 50% technically reach the diagnostic threshold for anxiety and depressive disorders. And 50% of those participants actually state this is in part due to their caregiving role. Care partners also tend to neglect their own needs as their responsibilities to their partners increase. So this means just taking care of their own day-to-day. So with lack of sleep, because we know that this is one of the things that those living with Parkinson's disease experience, it's also what their care partners experience as well. So insomnia, lots of symptoms that care partners are experiencing are due to the fact that they tend to neglect their own personal needs. In terms of quality of life, with increased burden, quality of life tends to decrease. Now, this is actually specific to the stages of Parkinson's disease. So as Parkinson's disease progresses, burden is increased and quality of life tends to decrease. Now, this is actually quite significant, as when the disease starts progressing, that's when they need a lot more care. So this is a very, very challenging time for care partners. Now, the lower quality of life means there's less ability to care for oneself and their partner. And with the increased the psychiatric illnesses. In terms of needs and recommendations, so while we're already very familiar with the impacts that Parkinson's disease does have on immediate, so the informal care partners, what the recommendations are from the literature is very much about finding ways to improve quality of life, as well as paying attention to care partner mental health through the process of Parkinson's disease. The psychotherapeutic process should consider the impacts on care partners and enhancing resiliency. So this is something that I'm going to be talking about next. So over the last number of years, resilience has definitely taken a turn in terms of what clinicians really want to adhere to when working with people who are challenging or have mental health concerns. We know how important resilience is. And so one of the things that we want to be able to do is to encourage resilience and improve it so that we can improve one's well-being. Now, understanding the aspect of resilience. So the American Psychological Association defines it as the process and outcome of successfully adapting to difficult or changing life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. So this is actually quite important. I feel as though the definition has actually changed a little bit over the last number of years. Now, resilience doesn't necessarily mean that those who would state that they are resilient have not experienced any trauma or major challenges or anything like that. It actually means that they have a much better ability to adjust and be flexible with the situation and the challenges that they are experiencing. Now, what's interesting is upon the review, high scores of resiliency measures were actually associated with active coping strategies, and resilient coping styles were correlated with higher quality of life, good mental health, and increased personal resources to help cope with chronic illness and reduce caregiver burden. So this was very important for me in identifying what are some of the approaches that could be beneficial within this population. So another really important aspect where there is less literature that supports this is that social support in PD caregivers may also be related to caregiver resilience. So it was noted that throughout the literature, social support tends to buffer the development of depression in the caregiver population. So this is very important considering this is one of the main concerns that we're dealing with when it comes to burnout and quality of life is they're noticing significant depressive symptoms. So this is noting that social support is actually quite important and can enhance resilience. So now that we are aware that resilience definitely has an effect or can be therapeutically helpful, we also want to consider what are some other aspects that are going to be important in order to help enhance one's resilience. So one of the most researched psychotherapy approaches would be cognitive behavioral therapy. So CBT is an evidence-based psychotherapy approach with demonstrated efficacy in the treatment of mental health concerns such as depression and anxiety, as well as a number of other mental illnesses. Numerous studies suggest that CBT leads to significant improvement in functioning and quality of life. However, few studies have focused on the PD care populations. CBT has also shown to be effective for several mental health benefits in caregiver populations. So just as just as a little bit of a background in terms of what CBT is, some of the core principles of CBT are to understand that psychological problems are based in part on faulty or unhelpful ways of thinking, on learned patterns of unhelpful behaviors, and people suffering with psychological problems can learn better ways of coping. So this is very much the premise of CBT, is we are very much focused on the patterns of how we cope and how we utilize our coping mechanisms and how they influence our behaviors. So what CBT clinicians tend to try to do is change the way that somebody might be thinking about something in order to encourage better behaviors and better responses. When we talk about addressing the gaps in the literature, so some of the things that have been recommended is to adhere to care partners, specifically PD care partners from a psychotherapy point of view. So when I take a look at this and I take a look at resiliency and CBT and the knowledge that we have on those and the effectiveness of those two approaches, we want to try to improve burden and quality of life within this population. So one thing that might be beneficial would be addressing the gap in the psychotherapy approach. So two psychologists in the US, so Dr. Christine Podesky and Dr. Kathleen Mooney, created a model to help enhance resiliency. So they created this model in 2012, and it's been utilized with a number of different populations. And what it tends to do is, or what the literature has suggested, is that it does enhance and improve one's resilience. So this is very much a strengths-based approach. So it's very individual, and it's a 4-step model to build the resiliency. Now, when I'm talking about the methodology in terms of what I would hope to do with my research, is I would utilize both a qualitative and a quantitative type of research. So focus groups. So focus groups working with PD caregivers to assess their needs, to engage with them, to identify what their needs are as a group. Of course, it would be to take a look at the personal model of resiliency via the 4-step approach. Certain measures, so this would be these are actually quite important. So the psychometric measures that would be used to decipher if the approach that it is that we're using, so this model of resiliency, is actually effective. So we would be assessing burden, we'd be assessing quality of life, and we would also be looking at the depression and anxiety scales. So another important aspect of this would also be to engage in discussions of clinical approaches specific to this population. So what type of approach would be most useful for this population moving forward? And in terms of the discussion, so identifying the needs and impacts of PD care partners is essential in order to address psychotherapy in the correct way. With increased rates of diagnosis of PD in Canada, working with the PD care partner population is critical. Utilizing evidence-based psychotherapy approaches has been promising, and so this is helpful in terms of finding different clinical approaches or solutions to work with this population effectively. Now, some of the limitations to note would be there's very little research that has been done looking at how to improve PD care partner quality of life. And also this particular 4-step model, the strengths-based CBT model to enhance resiliency, has not been used in a PD care partner population. So these are the types of things that we're keeping in mind as we're moving forward with the research. And just a quick thank you. I wanted to thank you to the Center of Aging and Community for having provided me with an opportunity to be talking about this very important topic. And I appreciate your time and consideration moving forward. Thank you.
Thank you, Andrea, for a great presentation. So at this point, I'm actually going to open it up to any questions. So you can ask questions by raising your hand or by writing in the chat. At this point, if you could just submit your questions or raise your hand, that would be lovely. Thank you. Lorraine.
Hello, and thank you, Andrea. I appreciate very much how you're research is continuing to build and address such an important topic as caregivers and care partners who are often left out of the equation in the healthcare system. So, I have two questions actually. The first one is, at one point you're using caregiver and care partner interchangeably, and yet on one of the slides you seem to distinguish it where the caregiver is actually also the partner. Because that can you just say a little bit about that distinction? Would that be okay?
Sure. I think it's one of those things where it sort of came to light, I want to say about 10 years ago, and I understood this from Parkinson Canada and working with the support groups, is they really resonated more with the term care partner as opposed to caregiver, as it was a relationship thing. They are the partners of the people who they're looking after, and they just thought it was a more appropriate term. Now, the reason why I'm interchanging the two terms is because a lot of the literature focuses on caregiver, the caregiver aspect. But typically from a research point of view, they do mean the same thing. It's just slowly sort of this turnover of terms and how people prefer to view themselves and how they feel with regards to their situation and what they think is a more appropriate term to be used.
So I'm curious though, when the caregiver is actually the life partner, I guess that's the piece that, and that's what I thought you were kind of coming to in one of the slides, because the caregiver has is very differently invested in the caregiving if he or she is the life partner, or they are the life partner.
Well, I think what one of the challenges is their roles change.
Yeah.
Right. So they do want to maintain the partner aspect. But unfortunately and realistically speaking, they are providing most of the care for their partners. They're giving care. So I think there's just this turnover in terms of how we can approach it, as it absolutely is a partner. And it's essential to be noted as a partner. And also they are providing some care, the care that they can during this time. So it's just one of those things that I think that actually might be really interesting research as well, in terms of how it's viewed and how people perceive the terms.
Yeah, I would think, but I also would think, a specific focus on actually the changes that the life partner lives when their spouse, right,
Absolutely.
is going through those stages, because I would think that gets lived very differently.
Yes.
I have another question, but I'll let other questions come and I'll come back if that's okay. Thank you so much.
Excellent. Thank you. I think the next person who had their hand up was actually Patricia. Go ahead. Oh, you're on mute, Patricia.
On mute.
Okay, thank you. Yeah, I just wanted to move that one a bit forward a little bit more into the community. So we're not looking at partners as sort of life partners or immediate family, but what about neighbors or old friends? And how do we start building at that community? Have you seen any experience of that in the Parkinson Society, where they're starting to emphasize the need for broadening the circle of support to neighbors, or friends? I'm thinking particularly of NORCs, the naturally occurring retirement communities, such as a lot of these condos in the city are full of older people. And how does caregiving move into a NORC?
I mean, from what I have noticed, Patricia, has very much been about finding ways for the care partners or family members to advocate for different types of supports. There isn't a lot of, from my perspective, or from what I have noticed or heard about, there isn't a lot of community engagement in this in terms of how to get the community more involved with the caretaking aspect. But I do know that there is this piece where care partners are being encouraged to advocate for the supports that they need from neighbors, from other family members, from the community. But directly, I don't know of any resources that are being promoted in order to engage more of a community approach.
Because I think that is then my final word on this before Nina asks her question, is that that's something we've really got to move into moving forward, because of the numbers that are coming through. The healthcare system just isn't up to it.
Absolutely. And it's similar to what we were talking about previously, Patricia, whereas, you know, those who are living alone or living with any, you know, chronic illnesses, they are usually the first to be placed in long-term care because they don't have any other supports available to them. Yeah.
Thank you. Thank you, Andrea. And that was a good presentation. Thank you.
Oh, thanks.
Great. Thank you. I think Nina Glinsky, did you have a question?
I think in a way, Patricia sort of framed it, what I was framing too, because from a personal experience, I actually saw this, and I journeyed with my brother who died about 5 years ago at 71 with Parkinson's. His Parkinson's was a rapidly developing disease, and just hearing today, it has given me a lot of comfort about what we didn't know as this was happening. I was thinking the education of the family and the importance of the family. As I was hearing you speak of partners and caregivers, I was sort of thinking mainly of, let's say, his wife, who was the primary caregiver, and wish to have that quite confined to her. When I say that, this is being taped, I guess, is it? But I feel there's a tremendous education that needs to happen about these diseases. I'm a member of a religious community as well. We have a number of our sisters who have Parkinson's or different forms of dementia, and we're trying to educate ourselves, but it's so important for the support of the person themselves who's suffering with that disease. And I would say one of the things that I sort of didn't hear is I feel, when I kind of journeyed with my brother, he was a very social person, and his male friends, which were his prominent support group, just disappeared. Literally disappeared. Not so much women who were friends of my sister-in-law who would support my brother in a certain way. So women really have a different capacity, I think, for caregiving, and particularly for those very limiting diseases that even his best friends hardly could be with him through this journey. He had one brother-in-law that was a tremendous support for him and could take him out and engage him in things that he was still able to be engaged in. But it's almost like the person dies and they still have a life ahead of them. And that's what I find quite... I'm an educator in what I learned about Parkinson's, I think, just because one of the main things, I'm talking too much here, it's not a question so much. I was surprised by your data. I really loved the information you gave today, because, and if that could be almost in a shortened form for people to have, it kind of enlightened me that just the 80% of Parkinson's disease persons might move toward dementia. Mm-hmm. That's an unknown for many who are engaged in it. I think the doctors don't have time to really educate. And a tremendous support from my brother and sister-in-law was a geriatric psychiatrist that saw them regularly. And at first, my sister-in-law was very open, my brother wasn't. And when he finally gave way with that, it was a tremendous support for both of them together. But I think my sister-in-law would have appreciated having her own time without my brother, so also therapy with the couple or with the caregiver, and the person is important, but the caregiver needs it for themselves as well. So I really was delighted with your presentation, and it was very helpful for me. It got me thinking in many directions, but I think the male caregivers have a different journey than the female caregivers, and that might be something to look at.
Absolutely.
Yeah, and the engagement of the community and neighbors too in understanding even what Parkinson's is all about. That, you know, persons have a lot of capacity for a while, and that's not to be overlooked.
Right. Thank you so much for sharing.
Sorry, I took a lot of time.
Oh,
No, I think that was like a very insightful comment. And in fact, there is a study that's currently being done. I'm doing it. We're looking at gender differences in caregiving and caregiving experiences. So I can tell you, yes, there are differences, and we're starting to see it in the data as well. So thank you for bringing that up. Tanya, I think you were next, Tanya. Go ahead.
Thank you, Andrea, for the lovely presentation. Sorry, just having some technical difficulties today. So in some of the questions that were asked and comments, I'm wondering, because of the family life partners as the caregivers, would CBT be the most appropriate approach, since you're looking at that relational aspect? Because you did mention spirituality in the first slide. And so with the loss of change in role, loss, change in perspective, meaning of life, and that connectedness with social impacts, would that be possibly an approach for burnout, for family caregivers? That was really my question.
yeah. So what is actually quite interesting, thank you for the question, is when I was looking at the research, many of the studies that I looked at were never specific with who the caregivers actually were. When I looked for specifics in terms of care partners, so their significant other, yes. So the CBT aspect, CBT and mindfulness were actually one of the most effective ways of working through the symptoms that they were experiencing. But many of the other studies were focusing on, so some of them were children caregivers, like adult children caregivers, some of them were family members, so sisters, brothers, whomever. But from what I recognized, or what I noticed in the research, was very much like the CBT approach, because it's so popular and common and effective to some degree, that was the most researched psychological approach. And it showed promise. So I would assume that if somebody is working at it from a personal strengths point of view and working through those CBT measures, I think it could be effective for caregivers, generally speaking, if that answers your question.
Yes, because I'm just wondering whether, if it's a social worker or a personal support worker, it can be seen as a job, right?
Right.
And so I can see how CBT might be appropriate because it's work, whereas a life partner would more be, it's personal, it's care, it's—
That's right.
Yes. So that's sort of what I was trying to find out, whether CBT for them may not be as effective or long lasting, right? It may be a short fix, but perhaps for more longer lasting effect for them, would it?
Well, I think what it is that we're looking at is we want to enhance resiliency by utilizing CBT as a way of doing so. So if resiliency is enhanced or improved by whoever the caregiver may be, whether it be a formal caregiver or an informal caregiver, we would hope to see similar results or long-lasting results. I would say probably about 70% of the research demonstrated that the CBT did have lasting results. So they were upon 6 months, 12 months, and I think 18 months following the intervention. So there was some improvement and it was maintained. And I guess, and again, it's very structured in terms of who it is that you're working with, right? So it's strength-based is what this approach tends to focus on. So it would be personal strengths. So whether you're looking at it from a family perspective or a care partner perspective versus, you know, a social worker, nursing staff, people, you know, formal caregivers, I would hope that it would have the same results.
Okay. Thank you.
Great question, Tanya. Patricia, back to you. I think you have a question.
Yes, well, actually, it was just to add something that both you and Andrea had commented on, and that was the gender of caregivers. I was with a large group of women this weekend, and so obviously I raised the issue of caregiving and the numbers of people that are coming down that will be needing to give and to get caregiving, and the gender difference that seemed to resonate with them. So that's a group of women, was the aspect of nurturing, because women nurture and men don't. Very few men. They nurture they protect, enhance maybe, but it's the touchy-feeliness of nurturing that has a lot to do with behavior. So I'm just wondering, Andrea, or even Stephanie, if you have any comments on that in your research.
It's difficult because one of the things is, primarily speaking from a Parkinson's disease perspective, it primarily is the female significant other, the female partner that is caring for their partner. But I'm not sure, Stephanie, have you noticed anything in what it is that you've
differentiate?
Yeah.
So what I will say is that for all dementia types, it is primarily women who are caregivers. So, you know, even if, you know, in the care dyad, it's the woman who has dementia, primary caregiver, sometimes it's the husband, but very frequently it will go to the next available female. So that will be a daughter, or it will be a niece, or it'll be a neighbor. So in the research, that's well documented that, you know, yes, there is a percentage of men who are caregivers, but it's predominantly women, okay, who provide caregiving. The research that we're doing has to do with the experience of caregiving, and, you know, what is the resiliency like? What resources do they tap in? And what are the gender differences of this in particular? So how do they cope? How are they resilient? And are there differences? And it's primarily a qualitative study. We are seeing differences, but it really is too soon for me to make, you know, generalizations or, you know, conclusions on the data as of yet.
Yeah, and I guess that my question was really related to, how does the caregiver relate to the one being cared for, and how effective is it? And that's where the idea of nurturing was, I thought, a very interesting part of the conversations that I had with others, and some of whom were caregivers.
I will add that men are perfectly capable of nurturing, but there is a socialization process that does get in the way that we need to acknowledge. So I have full faith that as generations go by, this will change. Yes, Lorraine, you had a question.
I have full faith in that capacity to. Sorry, I said I too have faith that as we transform the ways we socialize genders, that we will, I think, become more nurturing, or at least recognize nurturing in different ways. My question actually that I'm kind of holding has to do with resiliency and strengthening one's capacity to advocate for oneself as well as the person they're caring for within a system that is pretty fixed and becoming increasingly inflexible. Not that it wasn't before, but increasingly. So where do we put, how do you see this, your research sort of looking at that area? Because one of the questions you asked, I appreciated your slide with the 4 questions, and one is what can change? And of course, what we want is not only ourselves, but want the system to change, right? So that all can flourish in whatever way they can, right? So where do you see sort of that point of contact then with resiliency and increasing one's capacity to advocate?
Well, that's a great question, Lorraine. I think it's a bit of a challenge, because if I were to have this focus group with the care partners, I can guarantee you that that would be one of the things that they would like to change, right? So it would be the accessibility, it would be the system, it would be support. Absolutely. I have no doubt that that would be one of the biggest topics of conversation. However, when we talk about the resiliency piece, from a clinical perspective, resiliency would be adhering to and adjusting to the challenges that we are provided with. So the things that are outside of our control. So I think that there is this unfortunate piece where there's a lot of psychoeducation that can happen with regards to moving forward and advocating for oneself and their partner and the care. I feel like both have to change at the same time, right? So enhancing the resiliency, but also seeing some system changes with regards to how they are going to approach and help and provide resources. I don't think it's so one-sided, unfortunately. I think both things have to happen. Yeah.
No, thank you for that.
Thank you. Do we have any other questions?
I just wanted to say thank you to Andrea for that. And I do think it's an important issue going forward, you know, so I really, because I do see that connection in some way. So that's great. Thank you so much, Andrea, for thinking that through.
Oh, you're very welcome. And just to add to that, Lorraine, I was speaking with Patricia earlier. I've been asked to speak on a panel with Parkinson's Canada with a number of medical professionals in December. And so the topic is really going to be about how to create almost like a successful journey through the process of Parkinson's disease. So they're looking at psychiatry, they're looking at specialists, so neurology, psychotherapy. So there's going to be a number of us on this panel to advocate for this process to make it easier for people living with it and their care providers or care partners or caregivers. So it's an interesting thing. It's obviously people are obviously bringing it up as a concern. So I just wanted to touch base and let you know that will be happening, or it's in, you know, people are talking about it.
That's wonderful. Maybe we can put a link to your being on that panel.
Yes,
as a follow-up to this. That would be great.
Yeah, I think that's what we're planning on doing.
Great. Okay, thank you.
You're welcome.
Okay. Thank you, Andrea, for that wonderful presentation. I do need to rush out at 1 p.m. for a meeting. If there are any other questions, I know that Patricia can stay. Are there any other questions? So I will let everyone go because I do need to rush out for that meeting, but it was wonderful seeing all of you here. Thank you, Andrea, and thank you for attending our presentation. Have a good day.
Andrea, thank you very much. That was really very interesting and very insightful for people who are increasingly going to be engaged in caregiving. There's a wider audience for this, so thank you.
Well, thank you very much. And Patricia, in all honesty, if there's anything that you need from me, or if you think it would be important or something that you think I could help with in any way, please reach out. Please let me know.
Make this presentation again to another group.
Yes. Yeah. And I would be happy to do that. Absolutely.
Oh, great. Thank you very much.
Okay.
Thank you.
Well, thank you. Thank you.
That's great work. Really important stuff.
Thanks.
And thank you, Christophe, for stepping in.